Good morning, everyone. So my panelists have already been introduced. It's always a difficult task following sir, not only in rounds, but also on the stage. So we'll have 3 cases to be discussed with respect to solid tumors, 3 common cases we come across in our scenarios. So case 1 is a 26-year-old male with a right chest wall mass involving the right fifth rib. It was soft tissue mass, 11 by 13 by 12 centimeters. And there was a mass which was extending up to the right hilum. And there was no involvement of the left lung. On biopsy, it was CD99 positive, NKX 2.2 positive, such as Ewing sarcoma. As per institutional policy, he was started on EFT 2001 protocol after prior cisplatin plus etoposide. And response assessment done at week 11 showed that there was significant morphological and metabolic resolution of the mass. Consequent to that, he underwent a surgery. And on the basis of histopathology of the surgery, there was 55% residual viable tumor tissue such as Ewing sarcoma. So Dr. Ashish Gulia sir is not there, but Dr. Rajesh Bahadur is there. So I would like him to take this question as to what do you consider as high risk Ewing sarcoma and at what time point in treatment do you recommend surgery per se?
For this case, the residual mass is more than 10% viable tissue. So, and also the volume is quite high. It's more than 200 ml. It's a high volume. So it will be considered a high risk sarcoma. And I will prefer do the surgery after the NACT. It's because we have to, it's easy to resect. Morbidity we can avoid with the NACT, and also we can assess the chemo response. So I will prefer the surgery after the NACT.
Right. Is there any case in which you will consider upfront amputation if there was Ewing sarcoma involving the limb?
Pardon?
Upfront amputation. Any case, any indication of upfront amputation?
No. Sorry, please repeat, sir.
Any indication of upfront amputation in Ewing sarcoma?
No. So no. Not for the. I don't prefer upfront amputation, but if consider the mass is so big and impending to bleed, anyhow we can not going to the salvage the limb. Then we in the case-to-case basis, I prefer the upfront amputation, but routinely we don't follow the upfront amputation in any case.
Right. The next question is to my dear colleagues Lingaraj and Anand. Role of auto transplant versus conventional chemotherapy in such high-risk cases of Ewing sarcoma which is localized.
So this is a high-risk Ewing sarcoma, as Dr. Rajesh said, that's a high volume disease. And the most important thing to see is to whether this responds to chemotherapy. And a poor response to chemotherapy is something that tells you that it is a high risk and there is a high risk of relapse. So the Euro Ewing's trial has shown that if the viability, there are more than 10% residual cancer cells, and the risk of relapse is high. And in such cases, then doing an auto transplant upfront may have a survival advantage, because the salvage rates or the cure rates in relapses are very, very low. So the best treatment is the upfront treatment. So if it's a high risk disease, then doing a transplant upfront maybe will give us more chance of survival rather than waiting for the patient to relapse.
So Lingaraj, if this case was a metastatic Ewing's, would you have recommended autologous transplant for the same?
So as Dr. Anand said, that the data is very robust and solid for a high risk localized Ewings. But in the same situation, if it is a metastatic, for that matter, a limited metastatic disease, there is no benefit of doing autologous stem cell transplant. So probably as of now, it is a localized high risk Ewings where transplant has shown benefit in a randomized phase 3 clinical trial.
Right. As sir had said in the previous talk, given a resource constraint setting, if we have got 2 beds and we've got a patient who's got a high risk early disease rather than a metastatic disease, I'd rather transplant him early than wait for him to relapse, and then the chances of probability of survival will become very low.
Right. We'll skip this question if we have paucity of time. So next question, Dr. Ram. When do you counsel about autologous transplant in your patient Ewing sarcoma?
So when it comes to counseling patients for Ewing sarcoma for an autologous transplant, which we usually don't do in our day-to-day clinical practice. Because the reason being, one major thing is establishment of this autologous BMT as a standard of care in the management of Ewing sarcoma has only been done on the European protocols, which involve this 4-drug therapy, which is given 3 weekly. Rather, the subsequent trial of the Ewing has actually shown that that's an inferior protocol for the survival of for the survival of Ewing sarcoma. Rather, the North American protocol, which is the 2 weekly regimen, which is alternating cycles of VDC-IE, is found to be definitely superior over the wide regimen. So definitely right now in North America, that is the children's oncology trials, do not recommend autologous BMT as a standard of care, and they still continue to have comparable outcomes. Rather, they have better outcomes than the Europeans. So in my practice, what we do is a 3 weekly regimen because we fear the toxicities and the tolerance of these patients and the availability of the beds in order to put in all these FN patients in-house. So instead of aiming for auto BMT, rather we should aim for 2 weekly therapy to be delivered so that we'll have correct answer to our question whether these patients are responding well or not. Do they really benefit? But coming back to the auto BMT, definitely the Ewings 99 took 15 years in order to complete this trial, and the recruitment, although the eligibility was like around 600 patients in every arm, only 40% of the patients eventually went for transplant who were allotted. So when they were analyzed both on intention to treat and per protocol, it did show benefit, but it clearly shows that in day-to-day clinical practice how difficult it is to counsel, convince the physicians and the families to go for auto BMT in a condition like Ewing sarcoma. And so that itself is very clear in that publication, although it has shown benefit, but how much it is going to be. So if we have to talk to the family about this option of auto BMT, definitely we are going to offer it to the families who have localized disease, who have poor response in the form of less than 90% necrosis, and those families who have large volume disease, which would include most of our patients, because most of our patients will be large volume disease.
Two quick questions to Anant and Lingaraj. How do you work up for a patient for transplant, and which conditioning do you prefer in this patient?
So I'll take up the first question and Lingaraj will take the second. So first is to establish fitness of the patient for transplant. So we usually do a pulmonary function test, a cardiac evaluation with a Muga scan, or alternatively a 2D echo, a GFR test to see that the renal functions are adequate. Then liver function, the routine blood investigations to establish that the organs are functioning well. If that is there and the patient has a good performance status, then the patient is good enough to be taken for an autologous stem cell transplant. What you have to be aware is that you have to also look at the previous complications that have occurred during chemotherapy. So somebody who has got an MDR sepsis during his early chemotherapy, it is not a contraindication for autologous transplant, but if you know that the patient has had complications in the past, you will be more cognizant of it, and you'll be probably better equipped to pick up things early and maybe use higher antibiotics to ensure that the patient does not go into a bad MDR sepsis again. So taking a good history and physical examination is a must, and investigations to establish fitness.
Yeah, so coming to the conditioning regimen, I think the regimen that Ewings have used is a dual alkylator of busulfan and melphalan. So in our setting, that is one option, or you can replace busulfan with triosulfan to make it more better tolerable, because if you use dual alkylator, there will be more risk of mucositis and requirement of TPN and sepsis also. So Boomel or Triomel should be the conditioning too.
Right. So going on to the data, as my panelist said, so for high risk localized Ewing sarcoma, there was a randomized trial between Biomel autologous versus VAI, that is vincristine actomycin D plus ifosfamide as chemotherapy, and patients who had large tumor volume and diagnosis more than 200 ml, residual viable cells more than 10%, or those who had less than 50% resolution, as per radiological evidence were taken in this trial. And you can see that the median age was 17 years with a median follow-up of almost 8 years. Half of them had a high tumor volume and diagnosis, and the other half had a high amount of viable cells in the histopathology. And there was a benefit in both event-free as well as overall survival when you compare the BUMEL versus VAI chemotherapy consolidate. This was a trial in metastatic Ewing sarcoma where there was no benefit. So in Ewing sarcoma with pulmonary or pleural mets, there is no clear benefit of BUMEL autologous stem cell transplant as per the same group. So questions if this patient had less than 10% viable tumor cells and he proceeded to maintenance, there's a 4-year relapse in the lungs. So Dr. Ram, any impact of time to relapse and site of relapse?
When it comes to relapsed Ewing sarcoma, the outcomes are quite guarded. So what we can expect is only 15% of the patients would be in remission at the end of 5 years from the time of relapse treatment. So we have to choose wisely amongst the, wisely is like quite a guarded word, but we have to use try to choose the correct patients whom we are going to take up for the salvage treatment. So the most important factor which has been found to be of prognostic significance is time to relapse. So those patients who have relapsed 2 years from the initiation of the primary treatment, they are going to do bad. Probably they are going to be refractory to therapy. Whereas those patients who have relapsed late, that is beyond 2 years from the time of diagnosis, the initial diagnosis, they are going to fare better, where the contemporary chemotherapy protocols show a survival of up to 30%. So these are the people who are going to definitely do better compared to the early relapses. The other one being what we often see in the clinic is the site. The site, either it is only local or metastatic, it should be okay. But if it is disseminated disease at the time of relapse, then definitely we do not consider a curative intent. Also, we take into consideration whether this site was previously irradiated. So if so, then whether we'll be able to re-irradiate it, what kind of structures are around. And lastly, this time in relapse, if we have salvaged the limb, even especially if it's a limb tumor, so we would always try to go for an amputation surgery more in favor.
Right. Lingaraj and Anand, any role of autologous in situation with relapse Ewing sarcoma?
So as told previously, these patients, and Ram also iterated that these patients don't do that well. Even with transplant, the 5-year survival would be hardly 20-25% at the best. So, given the resource constraint setting, we would rather take patients who have a better chance of survival. It's not that we cannot transplant, but the relatives have to be told that the outcomes are poor and the chances of success of this treatment is very, very low.
Right.
I mean, if you see the corollary of metastatic setting, so there is a phase 3 RCT in metastatic setting, upfront setting, though there is no benefit. So yeah, apply the same kind of logic in a relapse setting, the biology will be nothing different. So though you'll not get a good robust data in this setting, but going by the logic, it will not help. Or even if it helps, the benefit will be very marginal to.
So as per data from the Germans, they have showed that those who have a late relapse after the first 2 years, they have a better prognosis in comparison to those who relapse within the first 2 years. And when it comes to the relapse, also it comes to the site of relapse, which is very important. Those who have a lung only relapse, they are much better as compared to other sites of relapse with respect to systemic relapse. If it's a multi-system relapse, then it's the worst. And this is a review of high-dose chemotherapy and ASCT for young patients with relapsed Ewing sarcoma. And you can see that the data primarily comes from the registry studies, and all of them are retrospective studies. They had some form of response prior to high-dose chemotherapy and autologous stem cell transplant. Majority of them received some form of melphalan along with busulfan or with busulfan or one study with thiotepa. And the 2-year survival with ASCT has been around 40%. In one study wherein they combined use thiotepa, it was around 60%. So coming to case 2, he's a young male with right scrotal swelling, LDH is high, AFP bit on the higher side, HCG is bit on the higher side, and you have a 7 by 6 centimeters swelling or lesion in the right testis with a lesion in the right inguinal region and paraortic lymphadenopathy also along with inguinal lymphadenopathy. He underwent a right high inguinal orchiectomy along with posterior wall repair. Histopath suggestive seminoma and corresponding IHC markers. PET CT showed that there is lymphadenopathy in that respective region, inguinal, iliac, and paraiotic. So diagnosis was a good risk seminoma. He received 3 cycles of BEP, after which he had a complete metabolic and morphological resolution. 3 months after treatment completion, he has a relapse wherein there is a iliac lymph node. At that time, tumor markers were normal. He was given salvage with TIP, that is paclitaxel based chemotherapy. And post 3 cycles of TIP, there is some morphological reduction in the lymph node size with no significant metabolic activity. So the question is, Dr. Himanshu Pandey, will you consider lymph node biopsy in this case? And in general, how do you prognosticate these relapse cases of germ cell tumors?
So to answer your second question, as this was a pure seminoma, and initially to present with the patient was having inguinal and iliac lymph nodes. It usually happens in the setting of high burden of the disease in the retroperitoneum or scrotal violation. So I don't know whether the patient was underwent some kind of FNAC in the form of through scrotal route or not, because retroperitoneal bulk is not there. I think 4 centimeter of the lymph
Yes,
node is there.
yeah.
So again, maybe the patient might have gone to some general physician or some general practitioner, and FNAC must have been done. Otherwise, usually routinely we don't have inguinal lymph node or external iliac lymph node as a presentation with the seminoma or non-seminoma. So to answer your question, the patient experienced relapse in the form of external iliac lymph node. So there is a definitive role of lymph node biopsy, especially in cases where early relapse is there, especially after complete response after first line chemotherapy, because seminoma, recurrence of seminoma in up to 30-40% of the patients, they recur as teratoma, that is to be ruled out. So there is definitive role of lymph node biopsy in this case. So FNAC was done only, that showed seminoma, but I think biopsy should have been done.
The biopsy suggests a seminoma in that case.
So it means this is a viable tumor. So we should, I think, go for salvage chemotherapy.
Right. Anant and Lingaraj?
Prognostication.
Yes, prognostication. Yes,
So
sorry.
prognostication, we use a scoring system that was actually given by Loch and Baer. So that includes the primary site of the tumor in the form of gonadal, extragonadal, or mediastinal. Basically, this is a scoring system where the scores are given 0, 1, 2, 3, and so on. And based on the primary site and complete response or partial response or no response, then AFP after chemotherapy or beta HCG and all those things. So a score is a sum of 0 to 10 is summed up, and then it is actually the scoring system according to the histopathology is again added for seminoma -1, and so a complete scoring system is generated, and a scoring or a risk stratification of -1, 0, 1, 2, 3 for very low risk, intermediate risk, high risk, and very high risk is generated. So that's how we prognosticate.
Yes. Anant and Lingaraj, any role of autologous transplant in this patient?
Yeah, so in patients of relapsed germ cell tumor, the initial data were from Indiana University. They all were retrospective data, but there was clear benefit of doing a transplant versus just giving salvage chemo in relapsed germ cell tumor. And there is a big data again from Germany. It's a retrospective data. So these were the data based on which somehow transplant was used. But subsequently, there was a phase 3 study done by Europeans called IT94, and that was a negative study. It didn't show any benefit of doing a transplant in relapsed germ cell tumor. But though the study had a lot of limitations, as usual in all transplant in solid tumor studies, the accrual was not complete. It was underpowered. So subsequently, there was another study which is ongoing, but still that time, I think the data from the retrospective series looks that there is a benefit of doing a transplant. But again, we have to do it in set of patients where the outcome is better, like the patients who, as the Himanshu said about the prognostic scoring, and then you have to take the best out of the relapse group. So relapse group again is heterogeneous. So there is a group of relapsed germ cell tumor who will subsequently do well. Probably that is the group we should look at, rather than those of early relapse, non-testicular relapse, very high AFP at relapse. So they are the patients who are anyway not going to do well. So maybe selecting wisely will be the way to go.
If you take him for transplant, you will consider tandem or single transplant.
I think this again is something which is being explored in the phase 3 studies. But as per the data from the previous study, it looks like tandem is better. But we still don't have an answer yet whether tandem or single.
Himanshu wanted to say something.
In general, as far as I can remember, those patients who relapse early, and especially after complete response or incomplete response, they portend poor prognosis. So in general,
Yes.
for counseling to the patient, in general, those patients who relapse early, especially after complete response, they portend a poor prognosis. I think the 20 to hardly 20 to 30 or 40% somewhere around
Yes.
the late.
Yes. Yeah.
So as Dr. Himanshu was alluding to, the prognostication in relapsed germ cell tumors is from this data from Lawrence et al. From 2011. Was 1900 patients, primary site, prior response, the progression-free interval, whether it's an early relapse or late relapse, tumor markers levels at salvage, presence of liver, bone, or brain mets, and the histological scoring. If it's a pure seminoma, they are more better. They get -1, and you get a scoring based on various categories as per this. And you can see that you can classify a patient on very high, from high to very low, and the progression-free survival is much better in those who are very low in comparison to only 6% in those in the high risk. This is how we can choose our patients for autologous stem cell transplant relapsed germ cell tumors. This was the first trial which Lingaraj was alluding to, wherein they compared one autologous stem cell transplant versus conventional chemotherapy salvage, and there was no benefit. This was a randomized trial. And consequently, there is retrospective data from Indiana University, first published in NEJM in 2007, and subsequently in JCO in 2016, 2017 or so. And in the first paper, you can see that with tandem transplants in 184 patients, the 4-year disease-free survival in these population is 63%. But the problem with the study was that they took a very good cohort of patients. In the second study, 364 patients with a median age of 32 and a median follow-up of 3 years, the 2-year survival is close to 60%. And this is with tandem transplant, wherein they have used carboplatin plus etoposide as a conditioning regimen. So when it comes to salvage treatment regimens, you have multiple options. TIP has the best survival rates with respect to its curability index, but it is toxic too. And when you compare retrospective data of conventional dose chemotherapy versus high dose chemotherapy, the high dose chemotherapy is much better with respect to the PFS as well as OS. There is one randomized trial which is yet to be completed and published, that is a Tiger trial, where they've compared the best salvage TIP versus TICE. The drawback of this is when you look at the first 2 cycles, they are of paclitaxel and ifosfamide, and it is followed by 3 tandem transplants. I'm not sure whether it will be feasible in our setting. So coming to the last case, is a young boy with posterior mediastinal mass, biopsy suggests neuroblastoma. MLPA NMIC is not amplified, but there are multiple chromosome gains and losses. The PET scan shows disease in the mediastinum, supraclavicular lymph nodes, pleural deposits, marrow lesions, Curie score of 2, and the bone marrow is involved. He is a non-infantile neuroblastoma with bone marrow involvement. Question to Dr. Ram: what is high-risk neuroblastoma and how do you counsel him in your setting?
So neuroblastoma is one of the most common pediatric solid tumors which we encounter in the clinic, and it has got this fascinating spectrum ranging from treatment might involve observation to very discouraging results in spite of multi-modality treatment. So high-risk neuroblastoma is that proportion of patients in neuroblastoma who do really bad. So they are basically patients who have non-infantile disease, who have metastases, or the metastasis is commonly to bone marrow and skeletal system. The other group is those patients who have NMIC amplification on molecular testing, in spite of it may or may not be metastatic. So these patients, historically, they have been doing worse. So they involve multimodality therapy, where we first start them on induction chemo, and then post-induction chemo, what we expect them to is to attain a good response in the metastatic sites. That should be either a metastatic complete response or a very good partial response, where there are defined criteria, following which only we can proceed to further treatment. If they have not cleared the metastatic site, especially the bone marrow on aspiration and biopsy, it's pointless to proceed with further treatment. That's one thing which we all need to remember. Then when we move on to further steps of treatment are consolidating the induction in the form of surgery and the bone marrow transplant. So the autologous BMT has shown benefit, especially it has shown benefit even pre-immunotherapy era in improving EFS, although not OS. So here, after the immunotherapy, advent of immunotherapy, the autologous stem cell continues to be relevant. And so we do auto BMT followed by radiation to the local site and then move on to immunotherapy, which is of prohibitive cost in our setting. So in India, currently, most of us practice, apart from immunotherapy, we take auto BMT also as a part of treatment, and the outcomes will be ranging of 25 to 30% of 3-year EFS is what we can expect. If the immunotherapy can be procured from abroad, the outcomes will improve to around 60%. So those children do definitely better if they have access to immunotherapy. Also, recently, the tandem transplant has also shown to improve the outcomes in high-risk neuroblastoma. So all this should be taken in context with immunotherapy, definitely.
This patient received rapid co-check, achieved a metastatic CR, bone marrow was negative, underwent excision of the mass. So Ram has already covered this in his talk. But one last question: which conditioning regimen, Anant and Lingaraj?
So the standard regimen is Bumel. That is the regimen for which there is most data. So 4 days of busulfan and then melphalan. We've now started using triosulfan because of lesser toxicity, but the data and the trials the data is more for Bumel. So any of the two regimens.
So similar to Ewing sarcoma, here also Bumel. So this was a trial. Yes, Ram.
So like how Sir said, both in Ewing's and also here in neuroblastoma, especially neuroblastoma, we do a lot of transplants, so we encounter. Post busulfan, we see a lot of toxicities, especially when we're giving immunotherapy. We have seen patients developing pulmonary toxicity. So when we reviewed with people who are practicing immunotherapy, so they are definitely recommending us to move to Triomel. So probably that should be started in practice.
Something very important for practice. This was from the COG study wherein they compared autologous BMT versus conventional chemotherapy, and the event-free survival was 10% higher when it compared to the autologous transplant. And similarly, we can see here not only the survival is respect to the event-free survival benefit. And they not only randomized to autologous BMT, but also to cis-retinoic acid as maintenance. And the top two curves are for BMT, and cis-retinoic acid is partially better than those without non-cis-retinoic acid. And this is a Cochrane review, wherein we can see that there is not only a benefit with respect to the event-free survival, but also the overall survival. 20% patients survive better more in autologous BMT as compared to the conventional chemotherapy. With respect to the conditioning chemotherapy regimen, this was a trial from the SciOpen, wherein they have compared Bumel versus the older conditioning regimen CEM, carboplatin, etoposide, and melphalan. And there was benefit with respect to the busulfan melphalan, with respect to the event-free survival as well as overall survival. This was a randomized study, 300 odd patients in each arm. To take home messages, we have Ewing sarcoma's case, wherein we learned that there is a benefit in high-risk localized Ewing sarcoma and relapse cases, and Bumel conditioning is better. With respect to germ cell tumors, when it comes to prognostication in relapse cases, there is an international prognostic factor study group scoring as per Lodge et al. 2011, which is used. And benefit of autologous stem cell transplant in this group comes from the large retrospective data from Indiana University, and people conventionally do tandem transplant with carboplatin and etoposide. With respect to neuroblastoma, there is a benefit with autologous stem cell transplant in high-risk cases. Bumel is preferred over CEM. We can use triosulfan melphalan in our setting. So the last slide is of 3 neuroblastoma kids which we've done a transplant. While the first two know what they want to become, the third is still wondering what he wants to become. Although